Okay, so it's about 8:02. Hi everyone, welcome. My name's Jackie. I'm a third year MD student at a med school down in Florida. So today we're going to talk about interpreting EKGs. I'm hoping we have some aspiring cardiologists or maybe cardiac surgeons or people who are just interested in cardiology in the house because it's a super cool field. I'm going to be posing some questions during the session. I'm not going to cold call because I think it's kind of aggressive, but if you want to volunteer, please do. No judgment zone. I didn't learn a lot of this until I started medical school and just maybe a little bit picked up during shadowing. So you by no means need to know this information, but I think it's interesting and a nice primer, and EKG is something that you're going to see in every field you do, no matter what. So I guess I want to open with a question. Does anyone know why it's called an EKG and not an ECG? Oh yeah, you can put stuff in the chat too, that's fine. Yeah, okay. So it is the heart, that's correct. And Madeline, you're absolutely right. The K, yeah, it's German spelling, cardiac, it was the K in German. You guys are much smarter than I was when I was at your level. I'm gonna try to. Okay, so for those of you who haven't been to one of these before, we're gonna start with the case. Then we're going to go into the physical exam, talk through some differential diagnoses, go over the assessment and plan, and then talk a little bit about pathology. I'm going to be talking a little bit about how to just approach looking at an EKG or an ECG and kind of how to read it. So again, active participation is encouraged. You can speak up and unmute, or you can just put it in the chat. That's fine. I'll monitor it as I go. And then please fill out that SOAP note. I believe Becca put a link in the chat for that. So if you're not able to access that, let one of us know or raise your little emoji hand. Let me see what the chat says. Yeah. So here's the case. I'll read it out. We have Mr. Jones. He's a 67-year-old male who is presenting to the emergency room with chest pain. It started while he was walking up the stairs with groceries. He has had chest pain intermittently before, but it usually resolves with rest. This time he decided to come in because the pain was severe and sharp and was accompanied by shortness of breath and nausea. He has a history of smoking for the past 40 years and recently started trying to work out more to lose weight. So you guys should have your SOAP note up and should be taking down some of those details. Does anyone have any questions about SOAP notes? Or what information to be taking down? I really didn't learn about SOAP notes until medical school, so I think it's cool that you guys are doing that now. Questions?
Yeah, would you mind actually going over what to include in that, please?
Yeah, sure. So does anyone first want to answer that for Esha, and explain it to the best of their knowledge before I jump in? It's cool if not. Okay, I'll just do it. I didn't pause for long enough, but I'll just go ahead and do it. So SOAP is an acronym. S stands for subjective. So subjective is going to be, what does the patient tell you? So that's going to be like their name. We might call this the HPI as well, which is the history of present illness. So this is going to be when patient comes into the emergency room and I'm saying, what brought you in today? The story that they tell us subjectively. So he's going to say like, oh, an hour ago, I was going up the stairs with my groceries and it just like right here on the middle of my chest. And that would be subjective. So that's everything that's in S. So that would also include past medical history, family history, surgical history, medications, allergies. Did I say social history? Social history, and then just everything about what brought him in today. Severity of the pain, location of the pain, radiation of the pain. And you don't need to know all of these yet. So it's just anything that comes out of the patient's mouth. Now, the O stands for objective. So this is not anything that the patient says. These are things that we elicit from our exams, labs, and imaging studies. So then that would be the vital signs that we take is the first part of objective, always, always, always. Then we go into the physical exam as other objective things. So if he says, I came in because my shoulder hurts, or like if he says, I came in with chest pain, we'll just do this guy. If he says, I came in with chest pain, that's subjective, but objective would be if I'm feeling around on his chest and he goes, oh, that really hurts when you press right there, then I would write an objective physical exam, tenderness on palpation of the sternum. That would be an objective finding. I hope that makes sense. That was kind of hard for me to grasp. So it's vitals, physical exam findings, and then labs and imaging studies are all going to go in objective because that's not something the patient said, that's stuff that we objectively found. Now, A stands for assessment and P stands for plan. And honestly, in my mind, I kind of group those together. So assessment is going to be like, we're looking at this guy with chest pain, and we'll do this together as we go through the case. But the assessment is like putting together all the data from the subjective and the objective and kind of figuring out what our next steps are going to be. And then the plan jumps directly off of that. So if I have what my first problem is that he came in with chest pain, I have assessed that he has chest pain. It's likely one of these 4 things. My plan for him is going to be like, now let's take him for a chest x-ray or something like that. And that might be our plan if we didn't already do that when he was first evaluated. Does that make sense?
Yeah, that was perfect. Thank you so much.
Okay. I get a little wordy sometimes, so just, do this at me if I start rambling. So does everyone have their subjective data down for Mr. Jones as of right now? Cool. Okay. Questions to consider. So what are some things that we might consider asking Mr. Jones now that we have the first part of our, oh, hold on, there's a lot of stuff in the chat. Yes. COPD. Okay, COPD is a great first thought. Trish, why might you think that it's COPD? And angina is another excellent one. What does COPD stand for? The smoking history, right? So COPD is chronic obstructive pulmonary disease. Yes, exactly. So that is an excellent, perfect. Thank you, Jenna. It's a perfect thing to think of based on a smoking history. It should always be considered. And we have to remember that a lot of these diseases can happen concomitantly, meaning at the same time. So he may have angina, as Devani suggested, but he may also have COPD. So these are all things to consider. These are excellent differentials. Let's pause on the differentials until we get a little more data, but these are all really. Ask family history of heart disease. Okay, excellent, Nicole. Family history goes in what part of the SOAP note? Subjective, perfect. Yeah, so this is a really tricky concept, so that's why I'm asking questions. It's gonna be subjective because that's something that we're asking him to subjectively say to us. Objective is, again, vital signs, physical exam, lab, and imaging. So those are all things that we're finding on our end. It's kind of like that, don't trust the patient thing. So I don't know if that's the right way to put it, but objective is stuff that even if he was lying about everything, the objective part would be the same. If he came in with chest pain and then we're feeling around or he came in with shoulder pain and then we're feeling around and it doesn't elicit any pain, then we have to write subjectively. Yeah, we have to write subjectively that he has shoulder pain. Yeah. Okay, I'm getting too wordy again. Thank you. Any other questions we want to ask besides family history of heart disease, which is an excellent question. Medications is a great one. Medications, because there are definitely some that can cause musculoskeletal pain, or that can affect the vasculature, that may be affecting his cardiovascular system, his musculoskeletal system, his lungs perhaps, and those things can all cause chest pain to an extent. Like someone mentioned COPD, that's lung. He talked about activity level a bit. Yep, that's definitely, so that would go in what we call the social history, which includes drug use, smoking, alcohol, sexual activity, living situation, job, and then also physical activity would definitely be important here. So Mr. Jones mentioned that he was going up the stairs and that was when his pain started. And that's unusual for him. He mentioned that he had pain in the past when he moved, but when he would sit down and rest, that pain would go away. So definitely asking what his baseline level of activity is an excellent question to ask. Anything else? Think about other things that might be contributing to his chest pain, maybe questions you want to ask about the chest pain specifically. Is it localized? Yeah, absolutely. So we want, usually the best way to do that is to ask the patient to point directly to where the pain is, right? Because if they say my chest, like the chest could be here, chest could be here, chest could be way down by your stomach. So that's a great question. When did it start is usually the first question to ask, especially with chest pain. We want to know when it started, because if we're going to take them to the cath lab, you need a specific balloon to door, we call it, or door to balloon rather, time, or else they're not eligible to be cathed. So that is an excellent question to ask. When did it start? And that typically you could ask EMS when it started. What activities trigger the pain? K is an excellent question. So in this particular case, it's activity. It was relieved by rest, but now it's kind of with like more strenuous activity, like stairs is more strenuous than walking on a flat surface. So that would trigger the pain in this case, but that's a great question. Is he having referred pain? Madeline, is an excellent question, because a lot of times, typically, anginal chest pain or MI chest pain will radiate up the left side to the shoulder, down the arm. But importantly, Mr. Jones is male, we think. So he, if he were female, then this would present totally differently. It could present totally differently. Scale of 1 to 10 pain is a question that we ask. So we would definitely want to ask him that. Does it radiate? Yes. Throbbing or sharp is great. So we call that qualifying the pain. So it can be throbbing, sharp, pressure. Sometimes we'll, if they say like a horse is sitting on my chest, then we'll actually write that in the S part of the SOAP note and write, he describes it as a horse sitting on my chest. And we'll actually write that in directly, because that can help us later. Questions indicating stroke is great, especially if he has a history of atherosclerotic disease. So for that, there are specific scores that we can use for stroke. There's one called the NIH stroke score. And like, I just use my phone, and there's a little calculator on it called MedCalc that has a lot of these different scales. There's too many to memorize. And we just kind of like click them as we talk to the patient. So we can definitely do a score to see if it's possible he's having a stroke. Yes, timing, when did the chest pain begin? What makes it worse? We also like to ask what makes it better. So in this case, it would be when he rests. Maybe he read something earlier and took an aspirin, and maybe that has helped in the past. When did it start? Did he have any hospitalizations before the chest pain is a great question. So we do like to ask about previous hospitalizations and also about previous surgeries. Any history of addiction is an excellent question. Does anyone know why addiction is such an important question to ask for this particular presentation? This is a really tricky question. Drugs, okay, yes, drugs are bad. That's probably, that's a good answer. So drugs are bad. In this case, we might ask that for cocaine usage, because cocaine can make the vasculature go like this. And if he like just used cocaine, like I've seen patients in the emergency room before who are like, oh, my chest hurts for no reason. And we're like, did you do coke? And they were like, well, yeah, that's why you have chest pain, because your vessel did this because cocaine. So that's a great question for chest pain specifically as well. Great job on this, guys. Let's keep moving. Oh. And it's what I was looking for. How about on the physical exam? Any specific things that we want to look for? Okay, so enlarged heart is a great one. This is a very tricky thing to do, to find the enlarged heart on exam. Sometimes we can tap around the patient like this, especially in the abdomen, to see like if it's like kind of when you're on a wall looking for the place to like nail the thing in to see if it's hollow or not. I just learned that recently because I moved. But like you can kind of do that on the abdomen. We call that percussing. You can't really do that with the heart as much because there's a lot of stuff going on in the thoracic cavity, but we can feel for where the heart beats hardest against the chest. And if that's moved to the side, that can indicate that the heart is large. So that's a great one. High blood pressure is huge. I mentioned that the first thing we do in the O part of the SOAP note is vital signs. So blood pressure is going to be there. Any tenderness is a great question. So we're going to palpate all along the thorax. Bruising is another good one that can indicate trauma, which steers us further away from cardiac issues. Pallor is another good one that can indicate bleeding. We would want to confirm that with labs and see if he's anemic. Maybe he's losing blood. Murmurs is an excellent one. So we're going to listen to all of his valves and see if there are any murmurs that can cause pain depending on which valve is affected. History, occupation, sedentary. Yeah, definitely we want to ask about the job. Someone mentioned COPD. So certain jobs expose you to like coal miners is a specific one that you'll see in med school, can get coal into their lungs and that can cause certain diseases. That if it is to block up to a certain extent or even block up to the extent that it affects the heart, that can cause chest pain as well. So asking occupation is definitely important to see if there's any exposure. Shortness of breath is an excellent question to ask as well. And JVD. I am very impressed that you said JVD. That's a huge one to look for. Do you know what that might indicate if he were to have jugular venous distension? We would see that here on the neck. Asking if he has a history of anxiety or panic attacks is an excellent question. And that's actually, Nicole, that's one that I miss all the time. I shouldn't say that, but I do miss asking that question a lot of times because people can have heart attack-like symptoms if they're experiencing a panic attack. So for the jugular venous distension, I like to think of it as, since the heart is meant to be pumping blood out and the veins bring blood back in, if the heart isn't pumping effectively, then that blood is gonna like back up upwards from the stuff draining from the head. And it's also gonna back up downwards from the blood draining from the extremities. And so if you see jugular venous distension, meaning when they lay back, you can kind of see that jugular venous pulse is higher than it should be, that might mean that the heart, it looks like I paused in the worst possible position, but yeah, so then we'll see potentially backing up of the veins. So in congestive heart failure or something like that, we may see JVD. That's an excellent one. Anything else to look for? I'll mention one more that we look for in the cardiac system. You guys actually did an amazing job mentioning the main physical exam findings we look for this. I'm super impressed. Is edema in the legs. We call that pitting pedal edema, meaning that when you press into the leg, it kind of like leaves a little indent. And that just means that you're fluid overloaded. You might see some elderly people, not always elderly, but you might see some people wearing those compression socks. That might mean that those people are experiencing congestive heart failure. Like I was saying, when the heart doesn't pump effectively, the blood backs up in the veins, and that can raise the JVD up higher in the neck and can also back fluid up in the legs and cause it to even leave the veins and cause swelling. The water kind of gets trapped there, which is why when you press in, the tissue kind of like holds that little pit shape. And so we might look for that usually in a cardiac patient as well. But you guys really did hit the major ones. Excellent job. Any initial test that we'd like to order for this patient, Mr. Jones? EKG, yeah, we're gonna talk about that. So definitely we have to do, if someone says I have chest pain, we're gonna do an EKG on them. We do this on most patients coming into the ED. So that's definitely one that we'll do. Does anyone know what we might be looking for in the EKG? This is a trickier one. We're looking for a lot of things. This is kind of a trick question. Yeah, heart rate is a huge one that we're looking for. Electrical activity of the heart, ST elevation for MI. Yeah, okay, so these are actually all correct answers. We're gonna go through this when we do EKG, but we're definitely checking heart rate. Tanya is correct. We are looking at the electrical activity of the heart. ST elevations for MI is the big one that we're looking for. And we're gonna talk about what all of these different segments are later. And the QRS complex, Eliza, is correct. We are looking at the QRS complex as well, and I'll talk about that shortly. Okay, so here we're getting into the nitty gritty, a little bit more of his past medical history. So he has diabetes, dyslipidemia, hypertension, he had a hiatal hernia, poorly compliant with medications. Here's some of his family history of atherosclerotic disease. Mother died of an MI at 65. Father also had diabetes, past smoker, like we mentioned, works as a bus driver, but retired this year. So does anyone know what is important to kind of hone in on here? Dyslipidemia and diabetes, perfect. So those are risk factors for developing atherosclerotic disease or buildup of plaques in the arteries, which can cause an MI. Can also cause stroke, which someone mentioned before, so that can clog any of the vessels, really. But MI is the one that we're looking for today. Those are the main ones that I'm looking for, really. Hypertension is a huge risk factor as well. I threw hiatal hernia in there. You don't need to know what that is, but basically, if the stomach is sliding up this way through the diaphragm and the abdomen, that can cause GERD, which can cause chest pain. So I threw that in there because we have to consider when someone comes in with like retrosternal burning chest pain, it might just be GERD. They might just have like indigestion. So if they have a history of a hernia, we may want to consider that in our differential. So poorly compliant means that he's probably got high glucose on the labs. Family history of atherosclerotic disease is important. That just increases his risk. We mentioned the smoking. Bus driving is a sedentary occupation, so that's important just because he's probably sitting a lot, and that may be one of the reasons he developed obesity. Okay, so here's our physical exam. What part of the SOAP note does this go into? Yeah, subjective. Perfect. All right, so he's sitting up, he's in mild distress. Vital signs are heart rate of 110, BP is 150/90, respiratory rate is 30, temp is 97.6, O2 sat is 92 on 2 liters nasal cannula, meaning that little like nose thing that goes and you just tuck it behind your ears. So you're not expected to know what normal lab values are. So basically he has an elevated heart rate, which can happen when you're anxious, in pain, or depending if you have a certain pathology. He's probably just in pain, which is why his heart rate is high. His BP is high. That's probably, could also be pain, but it could be because he has high blood pressure not managed by medications. Temp is fine. O2 sat's a little low on nasal cannula. We'll talk about that. Someone mentioned looking for murmurs. So we're on the cardiac exam. Rhythm was normal. No murmurs, rubs, or gallops. We won't get into that right now. And non-displaced PMI. Someone had mentioned checking for an enlarged heart, and I talked about there's that spot on the chest where you can feel the heart beating the most. And if that's moved over to the side, then that might be a sign that the heart is large. So in this case, his heart is not enlarged, meaning he's probably not having a heart failure episode. Respiratory exam, he's got clear lungs. So someone had mentioned COPD. So now that would move a little lower on the differential. Still have to consider it with his smoking history. But no wheezes, rails, or rhonchi, meaning we're not seeing any blockages. He's probably not asthmatic. And no pedal edema, as I mentioned before, meaning congestive heart failure is much less likely. Questions about this? Does everyone have this down for the SOAP note? Because I know that this, I think, goes into it for you guys. Someone let me know when you're done so I know when we can move on. Okay, thanks, Tanya. I'm gonna move on, but if you need me to go back to it at any point, just let me know. So here's the labs. So other things that we wanted to order for this guy specifically, and you're not expected to know this, is troponin, which is a marker for basically cardiac cells dying and being injured. So that's high in settings like MI. So the troponin for him was high, white blood cells were high, otherwise normal. I actually made a mistake here. He should have high glucose because his diabetes is poorly managed. So you can just say elevated glucose in the SOAP note. That's my mistake. But otherwise within normal limits. But the main things we're looking for here are the troponin and the white blood cells. White blood cells being high typically means what in the body if we see that? Infection, perfect. So that's the main thing that we think of. Usually if it's like super, super high, then that we think infection. But also actually we can get what's called reactive leukocytosis. Leukocytosis meaning high white blood cells. So if your body is in a state of stress, like if you're having perhaps like a pulmonary emboli or something like that, and your body's like really stressed out, it can actually kick your immune system on, and that can raise the WBCs. So it's not always infection, which is maybe a trick question that could be asked. So the first thing to think is absolutely infection, but just remember, it can also be high just if your body is super stressed. So So a quirk of the ED is they always like to order a chest x-ray, so they're probably going to do that. Here, does anyone know some of the things that we're looking for? I'm not a radiologist. I'm not going to do radiology, but and I think they're still really hard to read. But does anyone know some of anything that we're looking for on the chest x-ray? Congestion, perfect. So we would see more haziness here in the lungs if he had like congestive heart failure, meaning again, his heart's not pumping effectively. So fluid is overloading. So yeah, we could see fluid. We could see fluid down here. We call that a pleural effusion. So we could also, if he had a traumatic injury, we may see blood or air, otherwise in the lungs. So we would see those here. In the heart, we may actually see an enlarged, what we call a cardiac silhouette. So if that looks big or if the heart is abnormally shaped, then that can mean a couple different pathologies as well. But for this guy, we're mostly looking to see, is the heart shape okay? Does he have any fluid buildup, as people mentioned, in the lungs? Any pneumonias? This here is his trachea, this lighter part here. So we're making sure that it's not shifting to one side or the other. It's not blocked, it's not compressed. And those are really the main things we're looking for this guy. And then any traumatic injuries to the bones, just for chest pain. So yeah, this chest x-ray is a normal chest x-ray. Okay, the other thing, everyone resoundingly mentioned EKG. You are not responsible for reading this yet. We're gonna go through this in individual parts in the next part of the lecture. So you don't need to lecture in the next part of this talk. So anyway, this is a normal EKG strip. You're gonna see so many of these, but we're gonna go through it. So don't worry about this yet. Oh, okay. So here are a couple differential diagnoses. I'm so sorry, but questions about what these mean or any other differential diagnoses based on the way that he presented. Any clarification on like angina versus MI versus pericarditis? Could I briefly explain those three? Sure. Does anyone first want to jump in and take a stab at it before I go ahead and do it? It's okay if it's off. You would like some things. Sure, but does anyone have about any of them, not necessarily all three? How about myocardial infarction? Can someone talk to me briefly about just what that means? Heart attack, right. So that's a heart attack, but what's causing the heart attack pathologically in the heart? Before we had atherosclerosis, perfect, yeah. Yes, okay, you guys are all correct. So it's a lack of blood flow to parts of the heart, coronary vessel block. Yes, you guys are all absolutely correct. So it is it's a combination of actually everything you guys said. So atherosclerosis, like we mentioned, this guy has a lot of risk factors: smoker, diabetic, obesity, male, older. All of these things can contribute to atherosclerosis. And that can block up some of the many vessels supplying blood to the heart. And we'll actually see specific characteristic changes on the EKG depending on which vessel supplying to the heart muscle is blocked. So that's correct. How about acute pericarditis? Angina's chest pain on exertion. Yeah, perfect. Very good, Vani. So angina means chest pain. So we have typical and atypical angina. So we have angina that angina is basically pain due to lack of blood flow, as she said. So the questions we're going to ask is like, when you move, does it get worse? Or if I'm just sitting here, do I get like chest pain when I'm not exerting myself at all? So typical chest pain or typical angina is going to be on exertion. So the fact that this happened when he was walking up the stairs and not just when he was like sitting in his easy chair makes this more likely typical angina, which points us more toward myocardial infarction. So that's one of the questions we want to ask, like, when did it happen? What were you doing when it happened? So that's an excellent explanation. And yeah, acute pericarditis is infection of the pericardium, which is a layer of the sac surrounding the heart. That's perfect. So basically there's a little pocket around the heart kind of protecting it. So as it's beating, it's not like rubbing against the lungs. So it's actually a 2-layered pocket like this. There's one basically right on top of the heart, and then there's another one, and then there's some fluid in between, just so as the heart is pumping, those layers can kind of like slide over each other easily, and the heart doesn't get aggravated. So if one of those layers becomes infected or inflamed, that can cause chest pain, which can actually produce changes on the EKG. And it can actually produce ST elevations on the EKG, which is confusing for MI. So you can't always just look at the EKG. So questions we might ask for pericarditis is like, did you have an infection recently? Or even an MI can cause pericarditis. So that's another thing that we'd want to consider. And I think in the cardiac exam, I mentioned no murmurs, rubs, or gallops. So we can actually hear if the layers are inflamed enough, it rubbing, and it sounds like a sandpaper, which is kind of creepy. But so that's pericarditis. Any other things to go on the differential diagnosis? Typically, you'd like at least 3. I think when you're doing assignments in med school, they like you to have 3 differential diagnosis, but like in life, it's okay to have a longer list. So anything else? Someone had mentioned COPD earlier, which I think is maybe not what's bringing him in today, because we're thinking this is typical chest pain, but we may want to look for signs of COPD. Okay, that's fine. That's fine. We talked a lot about this. So assessment and plan. So this goes into your SOAP note again. This is the A and P. So we saw his EKG earlier. There were ST elevations. I'm going to talk about how to identify those later, but in your objective finding, you're going to write for EKG, which is one of the labs or studies that we did, which is an objective. EKG, you're going to write ST elevations. And you don't need to specify what leads as of this point. But so he had a STEMI. So management of the STEMI, now that we identified it on EKG, on arrival, we're going to start him on an O2 nasal cannula, which is why I mentioned that he had that in his nose, because someone was like, oh, you might be having an MI, give him oxygen, because his pulse ox was low. We're going to give him sublingual nitroglycerin, morphine for pain. So the nitroglycerin is basically going to open up the vessels. So if I'm not getting blood to it, it's just going to try to open those up. Morphine is because it hurts if your heart muscle is dying. Aspirin can also help as kind of pain relief, and can also help a little bit if we're like forming clots in the vessels. It can help a little bit to dissipate some of those clots. So that's the main thing that we're going to give: oxygen, nitroglycerin, morphine, and aspirin. We don't always give all of these things, but this is kind of part of one of the main algorithms that we use. As we mentioned, we're going to give the patient an EKG, and we're going to kind of keep those leads on him so we can keep watching the EKG moving forward. And we're going to usually do that for 24 hours. We're going to monitor serial troponins, meaning we took that one, we take that as a blood measurement, his troponins, and we're actually going to monitor those over time to, does anyone know why we might want to monitor his troponin levels over time rather than just taking it once and being like, oh, they're high? Any changes are getting worse? Yes, these are all excellent. So changes are getting worse. What is the primary? Yeah, you're absolutely right. You may recognize troponin from your biochem or your bio class. It is a muscle contraction protein. That's why we're looking for it in the heart muscle. Basically, if the cells are dying, then they lyse and they break up. So if we're seeing free troponin in the blood, that means the cells in a primary muscle like the heart has died, and it's going to open up, and that's why we're seeing it in the blood. So the main reason we're looking for it is, like Sanjana said, to see if it's getting worse. Actually, Madeline as well, we're looking for reinfarction, meaning if we already had an MI, we're looking to make sure that it doesn't happen again in the same place or anywhere else, and also to see if they're trending downwards. In medicine, we like to look at trends rather than just one value at a time. And then I mentioned the door to balloon time. So depending on when his chest pain started, he may be a candidate for cardiac catheterization. meaning we're just going to go right in there and stent open the vessel to open it back up. So we can do that. We can also give him medications that bust the clot in his vessel, but there's a lot of factors that you don't need to know right now that determine which we do. And then other things that go in assessment and plan, remember, it's not just the thing that brought them in, it's everything globally about the patient. So other things we want to address is his smoking, making sure that he's feeling good about his smoking cessation plan. He mentioned that he started working out recently, so making sure that he's good on like weight loss and diet plan. Medications, so he would have been given medications for his diabetes, blood pressure, dyslipidemia, should be on a statin. So we want to counsel him on the medications, make sure that like, is he having trouble getting to the pharmacy? Is he not really sure why he was prescribed the meds, so he's not taking them because he thinks he doesn't need them? So we want to make sure that he's good on that. He's able to get his medications. And of course, we want to counsel him, 4 and 5 are similar, counsel him about the diabetes and make sure that he understands what it is and why he needs to be kind of making lifestyle changes and also taking his medications. So this is mainly the assessment and plan for this guy. Does this make sense? Is everyone good on that part of the SOAP note? We are Gucci. Awesome. So now we're going to get into the fun stuff. So people had mentioned earlier, myocardial infarction is in fact clotting of the vessels. So you don't need to know about the types of MI. But basically we have a plaque in the vessels of the heart that are, you don't need to know all of this jazz. This is way too much. But basically the vessel is blocked when when the cells aren't getting oxygen, they die. And when they die, they explode and they release different enzymes into the blood that we can monitor to look to see if the cells have died. And we can go in there and give drugs, like I said, to bust these clots up, or we can go in and stent the vessel open. Okay, so now we're getting into the fun stuff with EKGs, which is one of my favorite things. Someone had mentioned way earlier that an EKG is basically a look at the conduction system in the heart. So does anyone know how many electrical nodes there are in the heart? This is a tricky question. 2. Oh, it's not tricky. Most of you know it. Awesome. So there's 2 nodes in the heart. There's one here and there's one here. So what you need, yeah, perfect. Good job, Kendra. So we have the sinus node and the atrial node. So basically, or the SA node and the AV node. So basically sinoatrial and atrioventricular. So we have the SA node is where things start. Remember with the heart, things are always going in a vector downward and to the left. It's always going like this because we start at the SA node, we go down here, we pause for a second, and then we go down. So basically here, the atria contract like this, we go to the AV node, and then that pushes electricity down into both of the ventricles, and then those contract up like that. So it's like boom, 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 when we're beating the heart. So that's kind of roughly what we're doing. And we're kind of positioning electrodes around the heart so we can see the way that currents are moving through the different heart tissues. And it's physics and it's vectors, but it's not the scary bad physics that from undergrad. This is fun physics. So as was mentioned by Kendra, we have the AV node here. The top part of the heart's been cut off. You don't necessarily need to know these branches, but basically from the AV node, we split in 2 to supply both of the ventricles because they're bigger and they're meatier, and we need more oomph to kind of make them contract. So we can see on the EKG, the electrical activity going down here and down here. So if we had something affecting, say, this tissue down here, we might see what's called a bundle branch block on the left. And there are specific patterns on the EKG. We're not going to get into it because it's a little too nitty gritty, I think. But we might see blocks specifically on the heart because, again, we're looking at the heart from all angles. So if it's having trouble contracting this way, we'll see that on the EKG. So someone had mentioned earlier when I said, what are we looking for on the EKG? QRS complex. So that's this. And I'm going to go through each of the parts in a second, but I'm just trying to break this down in the best way possible. So the QRS complex is the main, like when you see a little tracing, that like part that we're looking for is the biggest part of the heart. I like to think of it as it's the biggest thing on the EKG. Therefore, it's the biggest part of the heart. Why do you have that spike? Yeah, good question. So yeah, it's ventricular depolarization. Perfect. So we have the biggest part of the heart, which is the ventricles, contracting up like this. And so again, because an EKG is a measure of electrical activity vectors, think of this is what we call positive. It's if it's above the flat line, positive, and if it dips below or is going downwards, that's negative. And EKGs run left to right. So here, when we're seeing this positive spike upwards, that means that the electrical activity, if I'm the electrode sitting on the heart here, and I'm like looking at the heart like this, that means that the activity is coming towards me like this, and that's this upward spike. Now, when we depolarize those cells, because we polarize and then we depolarize to make them contract and then relax, the depolarization is this part. And so that's, now I had seen it come towards me, that's this R going up, and then the S is it depolarizing, going back down away from me. And then I level back out once I come back to neutral because there's no electrical activity stimulating me. I hope that makes sense. This is a look at like all of the cells collectively. It's like a culmination of all the cells. So basically this upward is again, the electrical activity coming down the bundle branches towards the ventricles and then receiving it, and then it depolarizing. So that's all to make the heart do this in the ventricles. I hope that kind of makes sense. You don't really need to know all the nitty gritty. Just know the QRS complex correlates to the ventricle contracting, those cells polarizing and depolarizing. Does that make sense? It's okay if it doesn't. I'm happy to try to do it another way. I feel like my interpretive dance about heart contraction is maybe not helping. We'll move on, and if there's questions, I think. Thank you. Thank you, Stephanie. Okay, so now let's get into the whole thing. So again, like I said, the QRS complex is our big guy. And Kendra had mentioned ventricular depolarization, so that's correct. That's the heart trying to do this and contract. So the P wave up here is the atria contracting. So like I mentioned, we have the SA node up here. I hope you can see my pointer. The SA node up here, and that's going to cause the atria to contract. And then it's going to, from an engineering standpoint, the spikes are not a good sign. In medicine, is the spike acceptable? Yeah, we want to see that spike because that indicates that the heart is properly conducting electricity through the tissue. So actually, this is a good point. If we're seeing on our EKG as a whole, because we want to see actually how tall are those spikes. Because if those spikes are too tall, then that might mean that like the tissue is really fat, basically, so it's taking longer for the electricity to come through it. And if they're really short, that might mean that there's that we're not conducting very well at all. So we are looking a bit at amplitude as well. That's a great question. So again, P wave is the atria. Then we get into the QRS, which is the ventricle, and then we plateau. And then this is repolarizing after we've depolarized. Actually, I think I said that backwards before. This is correct. You're all correct, and I said it wrong. So we depolarize, we repolarize, and then we have a little, I'm not going to get into the pathology of the T wave, but that's all part of the repolarization of the ventricles, which happens a little unevenly because the left ventricle is a little bit thicker because that's where we're pumping blood out into the aorta from the left ventricle. So that's why those tissues hypertrophy. Just like when you go to the gym, your muscles get bigger, this side does more work. So this is our main EKG strip. I hope this makes sense. Again, atria, ventricle, get back to normal. So like I mentioned, an EKG is like a way to look at the heart from a bunch of different angles, which is why you'll see people with a bunch of different electrodes all along the heart. I don't know if I want to get into exactly how these limb leads work, but basically, this is a little bit too nitty gritty with the vectors. I just wanted to make the point that we have different angles that we're looking at the heart. So because if I have like one camera looking at the heart from this side, if I'm seeing pathology in lead 1, that might mean that something is wrong with that side of the heart. Versus if I'm seeing all of these guys have something weird in their EKG leads, that might mean that there's something wrong on the bottom of the heart. Sorry about this one. What quantity is the spike? Voltage or current? Voltage. You don't need to apologize. Questions are always encouraged. It's a voltage. I think we're in millivolts or milliequivalent volts. And does that make sense with the leads? We don't need to, yeah, no problem. We don't need to get into how we place these leads, but no, you know what? I'm gonna get into it. We have the time. So V2, 3, 4, 5, 6 are placed like along the chest like this. So that's kind of taking like a cut of the chest laterally. And then 1, 2, and 3 create like a triangle. You know what? I didn't explain it well. We're gonna move on because if I do more, it's gonna get confusing. But basically each lead looks at the heart from a different angle. We can correlate pathology in some of those leads to what part of the heart is being affected by pathology. Okay, so here is some math. Someone had mentioned the first thing that we look for in the EKG is rate, and that's absolutely correct. So you're gonna notice on most EKGs you see in the hospital that it reads it out for you and it says what is the rate. Always calculate it yourself as well. I use the cheat way because I'm bad at math. And so you'll notice on an EKG that there are thick lines and there are little lines. And the trick is that when we look at, does anyone remember what the peak was, that really tall peak on our EKG, what that wave or that complex was called? QRS, perfect, yep, and Stephanie, you're right, it's the R. The R specifically is the name for the peak, that top highest point on the EKG. So it goes QRS. And so this right here is the R. So what we like to look for is the RR interval can allow us to figure out what is the rate. How quickly is the heart beating? How quickly are the ventricles depolarizing? So here, if we count from, if I see an R here and then another R at the next thick line, that rate is 300. Super fast, they're probably dead. If it's here and then here at 150, at the next big line, then that's 150 is the rate. If it's the next one, it's 100. So the rule is 300, 150, 100, 75, 50. If it's slower than that, it's quite slow. And then you have to use the long method for math. But typically you're gonna see stuff. Does anyone know what the normal range for heart rate is? 60 to 100, perfect. Yes, in terms of BPM. It is 60 to 100. So typically you're gonna find patients somewhere in this range, meaning it's gonna be typically anywhere from 1, 2, 3 to like 5 big boxes away from each other. And you'll hear people call it like big boxes or little boxes. And this is specifically how much time, and you can math out how to get to those numbers. So now we're talking about MI, bringing it back to Mr. Jones. So as we mentioned, there's a thrombus in the artery that can cause everything beneath the tissue that's supplied by that artery to die. And dead tissue does not conduct electricity well. So that's why we're going to be seeing areas of change on the EKG, because that tissue is not conducting, meaning we're not going to see our normal PQRS complex. So injury means it probably happened recently. I don't know why this is necessary, but we have what's this dip called? Down here. Q, perfect. Q, R, and then this is why we call it an ST elevation, because this is the S, and then this would have been our T wave over here, which is inverted, meaning that we have reduced blood flow. So we sometimes call this tombstoning as well, because if we have really big STs, then it kind of looks like a tombstone, and we call it tombstoning also because they could die, which is kind of morbid, but that's medicine. So we're seeing ST elevations in the leads. That means that the tissue is probably dead or dying, meaning it's not getting blood. Importantly, I want to mention on a lot of EKGs, you're going to see, this was one of the first questions I asked and it made me feel really dumb. So don't feel dumb. A lot of them don't have Q waves. And I was like, it's the QRS complex. Where's the Q wave? Not all of them have Q waves, because Q waves in most cases are pathological, meaning if a patient has Q waves and you see that dip between the P and the R, that means that they have had an MI or they have dead tissue in the heart. I'm not going to get into why we develop Q waves because it's a whole class on itself, but basically not every EKG is going to have a Q wave. Don't stress if they don't. That's actually much better for the patient. So it's a way to see if someone has had an MI in the past, which is kind of cool, I think. Not for them. It's cool for like medically. Okay, so this is Mr. Jones' EKG. So I thought it would be fun for us to look at this together and try to kind of parse through it. So the first thing we look for is rate. So what I like to do is I like to find an R that's closest to a big line because I use my sheet method, and count the big boxes between them. So like to me, this one is pretty much on the line. So does anyone want to do the rate for me? Approximate is fine. It's okay if you don't remember the numbers. Just tell me how many big boxes there are. Yeah, oh, you guys all know it, perfect. 75, so it's pretty much, again, it's 300, 150, 100, 75. It's a little under 75, probably like 73, but around 75. So his heart rate is normal. It's between, I know this isn't what he had earlier. This is not, I made this case up. So he should be tachycardic. Maybe this is a later one. I don't know. He should be tachycardic, meaning it should be above 100. This guy is fine on this EKG. He's not too stressed. Other things that we look for are, now we start looking at the waves individually. So the first wave we look for is that first bump. Does anyone remember what that first bump is called? P, good. So it's the P wave, which stands for, you don't even know what it stands for. What does it signify? Atrial depolarization, good. So that means that the atria are working fine. If we're not seeing P waves, that's a big issue for him. That means that the electrical activity is coming from somewhere else. So I see P waves, that's good. Now we move on to the QRS complex. So here we're seeing no Q waves, meaning he hasn't had an MI in the past, that's good. RS, these are nice and narrow. We like to see nice and sharp QRS complexes if they're wide, and then that means it's taking too long to get through that tissue, because again, the QRS is a mark of like the ventricles contracting. So if it's a really thick QRS complex, then that means that the tissue is probably really thick, or there's something wrong with the conduction system down in the ventricles. So this is nice and sharp, which we like to see. And then over here is our biggest issues. So what leads are we seeing? This is a V, not a U. What leads are we seeing ST elevations in? Seeing those tombstones? These 1 through 4. Yeah, I see a little bit in 5 as well. I would, no, not 5. Yeah, let's say mostly 1 through 4. Mostly 1 through 4. 5 is getting back to normal. It's kind of like a little bit of a gradient. Again, if we saw ST elevations everywhere, that means something else. We're trying to localize where the tissue is not receiving blood flow. So we would know, you don't need to know what regions of the heart are supplied by which lines, because that's a little bit too in-depth, I think, for this crash course. But basically, we've localized it to the cameras that are looking at the heart from V1, 2, and 3. So somewhere in like the front of the heart is having trouble getting oxygen. So we've used this to successfully localize where on the heart we're having problems, which is super cool. So this is the regionally where it is. Again, you don't really need to know this yet. But so since we saw stuff from like 1 to 4, as was mentioned, this means that the LAD, or the lateral, the ascending, the lateral ascending artery, the left ascending artery, I'm sorry, I'm having trouble today with my brain, is having trouble supplying the heart. They call this one the widowmaker because this is the primary, it's kind of morbid. They call this, if they say like they had a widowmaker, then that means that the LAD, that front artery, which supplies most of the front of the heart, got blocked. And they call it that because a lot of people die from it. So it creates widows, which is a really sad thing, but that's what that means. So LAD was blocked in the sky. That's troubling. This is another artery left circumflex that goes around the heart. Right one obviously goes to the right side of the heart, and the PDA goes backwards and supplies like the back part of the heart and under. So again, we can localize, and we mentioned troponins. I just wanted to put this in there. These are some lab values that we look for as we see this rise in the first couple days. That's why, again, we look for it, because if it rises on day 5, that means we re-infarcted. CK&B is one that you'll see on tests, but no one actually does it. I got laughed at by a resident for suggesting that we take the CK&B. And these are my sources. I think we're right about at the hour. I'm happy to stay and answer questions if you guys have questions, or I go back. Will you start using an EKG device? Do you calibrate or benchmark it? You know, I haven't seen anyone do it, okay? Usually they just kind of roll the machine in, put on the leads, and press go. But I'm not really sure if there's a specific calibration. I think that the machine must do it itself, but to be honest, I'm not sure. I believe there's a short quiz for you to do in the thing. So if you can do that, that would be good. I hope you learned something. Again, I'm happy to stick around until you all want to leave if you have more questions. Cardiac system is my passion. I want to go into cardiac surgery. So I'm happy to sit and talk about cardiac stuff longer if you guys want to. Or if you want to go back through the EKG, whatever, let me know, or you can leave. The time is yours. So I'll just sit. Oh, and there's another session, I think, in coming up in a week or two that I'm doing about valve replacement. So tune in if you want to hear about valves. Next week we're talking about valve replacement. So I hope to see some of you guys there. Thank you guys so much for coming and participating. Can I talk a little bit about EKG lead placement? Sure. Let me try to go back to that slide. No, I'm not doing it right. Oh, I'm sorry, there was another thing. 10 questions. Yeah, so there's a quiz, try to get 80%. And there's more stuff in that Google folder that I believe was shared with you. And then next Wednesday is valves. So I think I can go back. So there's a couple different ways to do EKGs. There's like the fancy where you put like a sticker here, a sticker here, a sticker here. And you actually are really supposed to put like one on the ankle and one on the wrist to create those vectors, meaning like if I put like a positive here and a negative here, it's gonna flow downwards through the heart, and that's what creates that vector that way. And because the heart is like basically facing down and to the left, most of the leads are kind of like oriented down that way. So we're meant to ground. It depends if we're doing a 6 lead or a 12 lead. Normally in the ED, you're gonna see a 6 lead, but if we have kind of a confusing EKG, or like if we think that the thrombus is in the back of the heart specifically, we can actually place leads on their back or place additional leads and like do a 12 lead EKG to get a clearer look at the heart. But standard is we're gonna do 6. And so we're gonna kind of like line them up here below the heart, and we put some up here as well. So like this is our 6 lead. We're gonna put one here on the shoulder, here on the shoulder, here on the side, and then 3 on the bottom. This is our standard leads. And then we add these additional 6 if we're gonna do a 12 lead. And we can also, it actually I think goes up to V9. We can do 7, 8, and 9 on the back. We do those specifically if the back of the heart is obstructed. Any other questions? I love talking about EKGs. So if you've got more questions about maybe what different pathologies look like, stuff like that.
I have a question for you.
Yes.
Well, thanks for being very passionate about what you do. So how did you decide for cardiology or something?
That's a great question. So I'm kind of like a weird case. I've always known that I wanted to do surgery once I went into medicine. And then I shadowed in a ton of different surgeries. I shadowed in trauma, transplant, cardio, neuro, I shadowed all over the place, and I loved the trauma surgeries, but I didn't. And I found myself most interested in the cardiac system. And as I've looked into it more and as I've kind of gone through most of medical school, I have found that my fascination is deepest in the cardiac system. And so if I were to not go the surgical route, I would go into cardiology, which has a lot of different branches. You can do interventional, which is when you take someone to the cath lab to get a stent placed. They're the people who go ahead and do that. It's not technically a surgery done by a cardiac surgeon. You also have electrophysiologists, which are people who will put in pacemakers for the heart. And those are really the people who they know their EKGs better than anyone. And we have a couple other specialists with the heart. So cardiology is a field that is non-surgical, that's through medicine. And then surgery, you can go into cardiac surgery, thoracic surgery, cardiothoracic surgery, and that's the split. So I had always felt drawn to that field specifically. And I personally think the cardiac system just makes the most sense and is the most interesting. I'm extremely biased, so I'm probably not the right one to talk about other systems. But to me, this is just the coolest system. I think it integrates physics, biology, chemistry, biochemistry in a way that no other system does. And it makes a lot of intuitive sense. The heart is just one big pump that's fueled by one big circuit. And I just think that the brain doesn't make sense to me in the same way. It's a lot of this is probably happening here. And it's, I don't know. So I'm not a huge fan of the other systems. I don't know if that answered your question very well, but that's how I stumbled upon it. I basically just exposed myself via shadowing to fields that I liked. And the good news is, if you're not able to get shadowing in those fields, I know a lot of people are doing virtual shadowing now, but I don't really know if that's the same. In medical school in your 3rd and 4th year, you're going to do clinical rotations and rotate through a bunch of specialties. And that's when most people in my class are either deciding on what they want to do or changing their mind. I've changed my mind a bit from being dead set on cardiac surgery to maybe considering cardiology as well, because I did my medicine rotation. So people change their mind and you become exposed to these fields. And as you learn more about it, I thought that orthopedics was cool, and then we did musculoskeletal and I was like, never mind, I don't think it's cool anymore. So as you learn more about it. Okay, I hope that answered your question. I have read somewhere about non-ST elevation MI. How do they diagnose those if there are no ST elevations on the EKG? Is there a separate test for that? Okay, so this is a great question. STEMIs, or ST elevation MIs, are the ones that go directly to the cath lab. So if you ever see a question that's like, what do we do with a STEMI? Cath. Non-ST elevation MIs are the ones that, remember all those other questions we asked about okay, so there's a specific criteria that we use. It's called the Diamond-Forrester criteria, which is too specific, you don't need to know it. And it's basically criteria that we use to see if they're having typical angina or atypical angina. So typical angina is cardiac chest pain, meaning that something in the heart is causing that pain. So the Diamond-Forrester criteria involves chest pain that's worse on exertion. As we asked Mr. Jones, is it worse when you stand up and walk around? The second is substernal chest pain, meaning it's right here in the middle of the chest. If he's having pain up in his shoulder, it's probably not typical chest pain. And the third is it relieved by either rest, meaning if he sits down, it goes away, or nitroglycerin given sublingually. So if he meets those 3 criteria, that means he has typical or anginal or cardiac chest pain. And then we do an EKG to see if it's a STEMI. And if it's not, yes. And if it's not, then we will, we may not take them to the cath lab. They may be a candidate for clot busting therapy, meaning there are oral drugs or intravenous drugs we can give that will break up clots in the heart, or actually in all the vasculature. So we have to be really careful to make sure that they're not bleeding somewhere else, because if we're anticoagulating the blood, they just bleed everywhere. So we have to be really careful about giving those, or we may not cath them. We might just try to lower their blood pressure so that the tissue doesn't die. So STEMIs are the main ones that we're worried about, and non-STEMIs are a bit harder to diagnose. There's no specific test, but we are still going to look for, the main thing is going to be the enzymes. So the troponins, CKMB, which you don't ask for in the hospital, but is the answer on the test. we're going to look for the enzyme elevation, which means that those cells are dying and are lysing. That was the longest answer to say check the enzymes in the world, but that's what we do. I'm not sure, Becca, a student has asked me to leave my email in the chat because they're looking for shadowing opportunity. I don't know if I'm able to do that or if they can reach out to you about that.
Yeah, they can reach out to me.
Okay.
So my email is going to be at the end of the presentation, but it's just support@motivatemd.com. Or just reply to the invitation that you guys got or that you get weekly too. Either one. Yep, right there.
I bet, correct me if I'm wrong, Becca, but if they say like Jackie, who did the EKG thing, I can try to answer through Motivate MD if you have specific questions for me.
Yeah, totally.
Okay, I'm more than happy to do that. I love hard questions. Any other questions about hearts, MIs, other cardiac pathologies, not valve replacements because that's next week, but questions about anything else?
I don't have a question, but I have a nice comment to provide. I love your energy, and I also just appreciate how you're just being yourself in a presentation, and I really think there's a lot of value when a presenter is able to just kind of be themselves. And I know it might be because maybe we're a little tired, but as someone who has to crank out like 6 presentations every single freaking day, I love it even more that, you know, I'm not the only one who has that kind of same feeling of, you know what, just be the best version of yourself while you're presenting. So I just wanted to, you know, number one, thank you for putting up with my kind of, you know, funky, sassy comments here and there, but I do really appreciate it too.
Oh, thank you so much. I loved your comments. Thank you so much for participating. I've had a great time. Thank you so much. I really appreciate that. That makes me feel better. I feel like I'm a little spastic. So another student has asked, how to identify EKG for pericarditis? So that's a great question. And this is a trick question you're going to see a lot on tests. Thank you, Stephanie. Because it can also cause ST elevations. It's not for the same reason, and I really shouldn't get into why we see ST elevations in pericarditis, but the way to distinguish it is, as I mentioned, for EKGs, it's a way to localize where on the heart we're having issues. So we should be seeing it regionally. Where's the thing? We should be seeing regional elevation. So here we saw it here in these 4 leads, meaning it was the LAD. But if we saw ST elevations in what we call the precordial, meaning before the heart, so everything here in the front, if we saw ST elevations diffusely in all of these leads, then that's no longer just the LAD, but it's also like the whole front of the heart. That's concerning for pericarditis, meaning that like the whole front of the heart is having issues. And that's because the heart is not sitting backwards in the chest. It kind of like leans forward like this. And so when it beats, it like rubs forward on the heart, on the pericardium. So if this is inflamed and the heart is like rubbing on like rough inflamed tissue, that's going to cause issues diffusely on the whole front of the heart, which we'll see on the EKG. So that's why we'll see diffuse elevations. But the other way we're going to distinguish it, because we can't, so it is 2. What is 2? Here? Is that the diagram it corresponds to? So we won't, on the previous slide, 2. I'm not sure what you're asking about 2 specifically. I'm sorry. Just here, just confused on the ST elevations. So again, for MI, we're looking for dead tissue. That dead tissue will cause elevations in the ST segments regionally, depending on where it is. However, if the pericardium, not the heart, is inflamed and the heart is leaning forward like this and beating against inflamed pericardium, then everything, all of the leads looking at the front of the heart, which is going to be V1 through V6, all of those will show ST elevations just diffusely across the front of the heart. So 2, 3, and AVF actually look at the base of the heart down here. So that would be like that back artery that wraps backwards around the heart and down is having issues. And that would be why any of those leads looking up at the heart like this are recognizing ST elevations. But for pericarditis, it's going to be all of that stuff in the front diffusely, which we're not really going to see in an MI. However, other things we look for, because the answer in medicine is never to just look at one thing, or for pericarditis, we'd also look for, a lot of times these people will have chest pain, interestingly enough, more so when they are like sitting like this, and leaning forward will actually get rid of the pain. So if someone is having chest pain, you might ask them like, is it worth when you take a big deep breath? And is it better when you lean forward? Because the heart is sitting in a sac filled with fluid. So if you lean forward, imagine like a pendulum, it's no longer leaning on the inflamed tissue, which is causing pain. It's kind of like gonna release and sit a little bit off of the inflamed pericardium. So a lot of times people with pericarditis will like sit like this because it hurts less. So that's one thing that we might look for clinically. Also, they may have had like a viral infection that can affect the pericardium. And again, the ST elevation MI, we're gonna see, again, regional ST elevations, but also we'll see T-wave inversions, which we won't see in pericarditis, and they'll have that typical chest pain. So substernal chest pain, worse with exertion, better with rest. That was like a crash course in pericarditis. There's a lot more. Yeah, no problem. No problem. Other things to look for, I'll just ramble until someone stops me, are like rate we looked at. So we were looking for those RR intervals. Something interesting that can happen is these RR intervals can be uneven. So we had used it previously to calculate rate, but if we're seeing like one is like this, one is like this, one is like this, one is like this, does anyone know what it might mean if the RR intervals aren't consistent? If they're like all over the place? Just like intuitively, you don't need to know what the real answer is. Or maybe not intuitively, I don't know. Irregular beats, yeah, that's actually completely right. So typically what this will be is irregular arrhythmia, perfect. And the name for that is, yes, that's actually completely correct. So we might call that an irregular beat. Yeah, yay. It's called atrial fibrillation. So basically that means that because the QRS complex is coming from the atria, from the SA node contracting like this and causing QRS to happen, if the atria isn't contracting normally like this and it's kind of like doing this, then only some of the conduction is getting down into the ventricles, and this is going to contract like at a weird rhythm, and that will cause the RR intervals to be like all over the place. So not only will we not see P waves, because that P wave is only from that nice atrial contraction happening like this, we won't see P waves, or we'll see P waves that are kind of like staccato. And then we'll also see RR intervals that vary. So again, the main thing we're looking for, always look at an EKG methodically. So we look at rate, but we're also, when we're looking at rate, we're looking at RR intervals. And if they're uneven, then like that will take us down another path. But the main thing you're gonna hear with EKGs is like, always have steps that you follow. And if you're really interested in looking and you don't have to, there's a book called Dubin EKG something or other. It's if you just search Dubin EKG book, it's the best book out there for walking you through how to do EKGs. I took some screenshots from it because it like really holds your hand and walks you through EKGs. So that's a good one to look at if you're interested. How about EKG findings in VFib? Yeah, so that's a good question. So VFib is an interesting case. We will typically see, because the ventricle is not contracting properly, it's going like this. We're not gonna see, like I said, we're looking for those nice, sharp, narrow QRS complexes because the ventricle should contract like this. If it's doing this, those QRS complexes can become quite wide. So if we're seeing like, if you see like a wide kind of like big sawtooth pattern happening on the EKG, that's VFib. So that's like, that's actually the thing that kills most people when they go into like cardiac arrest. That's one of the only shockable rhythms that there is. So when they go like clear, they're looking really for VFib, because if the ventricles aren't doing this, then we're not pumping blood, it's not getting to the brain, and you die. So that's typically what we're looking for when we go to shock someone. And that's gonna be like big, wide, these things. So that's gonna look completely different than AFib. It's kind of a confusing concept, but if you think about it intuitively of like QRS is this, but it's doing this, we shouldn't be seeing a nice sharp contraction. It should be kind of like taking forever for the electricity to get down and through, because the ventricle isn't doing the proper thing. And then we probably won't even see P waves, because the V waves are so big. They're what we call buried in the V, in those big QRS complexes. So we're not even really going to see them, even if the atriate is contracting properly. And there's a bunch of different types of VFib too, which we don't need to get into, but some of them have like cool French names like Torsade de Pointe. And so there's a lot of they're deadly, but there's a lot of cool different ways that like the ventricles can fibrillate in weird ways. And they each have different treatments and different EKG tracings. Another comment, my dad passed away from a heart attack. I'm so sorry. Yay, I'm glad that you like learning about EKGs. Say that. Yeah, I think it's a cool thing. You're gonna learn technically how to read these in medical school, but I think just like being asked to like look at one and just kind of understanding vaguely what's going on, like, am I seeing P waves? Am I seeing Q waves? Like a Q wave is a cool thing to be like, oh, have you had a heart attack before? Not the way to start a conversation, but like a fun thing for you to know for yourself. Sometimes you can see little runs of AFib. Sometimes you might see like an escape beat. So we're seeing like QRS, 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 and then you might see like one big weird beat, which is just like sometimes your heart, like, it's an imperfect conduction system. So sometimes it'll like stutter. That's normal. So like you can see a little stutter happening in the heart. We can look to see if the QRS is kind of wide, if the interval between the P and the QRS is kind of wide, and just kind of looking at ratios. I think it's a really cool skill to have, and you'll hone it in medical school, but it's cool when someone's like, oh, you're a pre-med. Do I have cancer? Do I have a heart attack? It's cool to be able to be like, oh, is your ST elevation elevated? I don't know. I just think it's like a fun thing to be able to do at any point. So I'm glad that things are coming full circle for you, Stephanie. That's awesome. I remember I was shadowing and someone was like, oh, read this EKG, hard person. And I was like, what? So at least you can say one or two facts now if someone hits you with a question like that.